Hello, I'm Dr. Naveen Pemaraju, Associate Professor, Department of Leukemia, and today I'll be discussing with you BPDCN, Epidemiology and Historical Perspectives. BPDCN, Evolving Nomenclature Over Time. One of the most important things about this rare cancer is that it has had many historical names and name changes over the last 4 decades. A sampling of those names include complex names such as agranular CD4 positive NK cell leukemia, CD4 positive, CD56 positive hematodermic tumor, and blastic NK cell lymphoma. The problem with these names is that they sound like other cancer names, they can be confused with other entities, and with the change quickly over only a few decades, clinicians and pathologists may not be familiar with these latest names. Now, in 2008, the World Health Organization, or WHO, codified or solidified this current name of blastic plasmacytoid dendritic cell neoplasm, or BPDCN. Originally, in 2008, this unique entity was placed under AML and related family of neoplasms. Now, what's happened over the past decade is that a breakthrough occurred in that CD123, or the IL-3 receptor alpha, was noted to be a membrane biomarker of great significance in virtually 100% or all cases of BPDCN. Now, the structure of this IL-3 receptor is very important. IL-3, IL-5, and GM-CSF are receptors that all share a common signaling subunit, the so-called beta subunit. Now, each of these 3 receptors is a heterodimer, and this IL-3 alpha, which is CD123, IL-3 receptor alpha, is the cytokine-specific subportion that's of interest to us in BPDCN. This entity is found on pluripotent progenitor cells, and it's involved and promotes cell growth, proliferation, and differentiation. Now, this IL-3 receptor alpha is also known as CD123, and this will be important as we go through these slides. Before we get to that, in 2016, the latest reclassification of the WHO, the name BPDCN remains, but now with greater understanding of the pathobiology and its unique clinical course, BPDCN now has its own separate classification under myeloid neoplasms. The triad of CD123, CD4, and CD56, or think 1, 2, 3, 4, 5, 6, allows pathologists and clinicians to have a more unique and easy to remember way to diagnose this complex disease. Now, when you're talking about rare diseases, we must discuss incidence and prevalence. Well, in short, in BPDCN, we don't have a good understanding of the absolute epidemiology and incidence. Historically rare disease, as we mentioned, many name changes, as we discussed, but also in addition to this, there is a level of complexity involved in actually making the diagnosis and recognizing the entity. Just how rare is BPDCN? Well, it makes up only 0.44% of all heme malignancies and only less than 1% of all cutaneous lymphomas. A recent SEER database that we conducted showed that probably an incidence of 0.04 cases per 100,000 is a good estimate in the United States. And what about the historical outcomes in BPDCN? Not many reports in the literature in this rare disease, but a sampling of the largest series in the world literature, these are 30 patients or more, really reveal a CR rate of only about 50% or less in most published series. This is usually using standard AML type criteria, and of course, notably, early high death rates have been noted in the majority of these series. The median overall survival, as reported by most groups, is generally around 8 to 14 to 15 months, around 1 to 1.5 years median overall survival. At our own institution at MD Anderson, our experience dating from 1998 to last year, 2018, reveals that overall patients continue to do poorly over time with this rare aggressive disease, but that patients who are treated with certain subtypes of therapies, possibly with high-risk ALL-based or hyper-CVAD in the frontline setting, may fare a bit better. But overall, whether a patient has BPDCN in the skin or the bone marrow or both, generally the outcomes have remained very poor for these patients. And so as we think about BPDCN and treatment approaches over time for a historical perspective, A lot of our colleagues have used traditionally localized therapies such as radiation or even skin-directed therapies. However, as the greater recognition has unfolded that BPDCN is really a leukemia, a systemic disease, a systemic cancer, this has evolved into using multi-agent systemic chemotherapy regimens, intrathecal chemotherapy, and some of the options have included borrowing from acute leukemias or lymphoma-based therapy with mixed or suboptimal results in most patients. Now, most patients with BPDCN are older and unfit, so even these chemo regimens are not applied to the majority of our patients, and so other approaches such as hypomethylary agents have been used in the past. So in the modern chemotherapy experience, patients with BPDCN are often put forward for some type of a high-risk leukemia protocol such as ALL with the hyper-CVAD regimen, which includes intrathecal chemotherapy and consideration of stem cell transplant in the first remission for those fit patients who qualify. And finally, the last part of this story is the recent phase 1/2 clinical trial of tagraxofusp, or SL-401, which resulted in FDA approval in December of 2018 and represents a major new standard of care for patients with BPDCN. Thank you for your time and attention. Good day.